Can you please write your names in the chat and your location, and that will help us very much to know you better. Hello, everyone. Good morning and good afternoon to everyone from wherever you're joining. Can you please put your names in the chat if you can, so that we can recognize you and we can welcome you. Dr. Pronaza from Ukraine, thank you for joining and for putting your name in the chat. We have 63 people on the call already. Thank you. Dr. Yada from India, thank you. Thank you for joining us. Dr. Rudy from Malaysia and from Cambodia, you're all welcome. It's 9:02, and I think we'll start right away. So thank you for joining us this morning. This is the second session of our hepatitis webinar series for country program managers and policymakers. My name is Dr. Fumi Leshi, and I'm based here at WHO headquarters in Geneva, where I lead the hepatitis program and coordinate activities across technical teams for country implementation. Our discussion today is on hepatitis B elimination of mother-to-child transmission in the context of triple elimination as requested by you all at the last session in December. I'm joined here with my colleagues from the WHO headquarters, from the regional offices of WHO, and from multiple country offices of WHO. Now, the goal of this meeting is to facilitate knowledge sharing and exchange of implementation experiences by national program leaders and policymakers from different countries across the 6 WHO regions. We recognize that public health elimination requires government leadership and collaboration. So you are all at the center of our dialogue, and we hope to co-create the content for going forward with future meetings. So before we start, I want to quickly highlight some areas of logistics, sound quality, and housekeeping. Next slide, please. Right. So in terms of housekeeping, there is interpretation available in English and French. And as shown on the screen, you can click on this interpretation and choose the language you'd like to hear. There's live transcription, which you would need to enable, and it will appear on the screen. And we invite you to use the chat feature for questions regarding the topic and the presentation. Next slide, please. And please rename your Zoom ID to identify yourself, starting with your first name, last name, and country, and the example is right there. And please note that the session is being recorded, and all of these recordings and PowerPoints will be shared with you after the webinar. A certificate will be available through the University of New Mexico via links in the chat at the end of the session. Next slide, please. So just to set the scene, now that slide with the multiple, with the documents, can you bring it back? So before we start the scene, I would like to, we know that hepatitis B is a major public health threat with a global burden that exceeds 300 million. So can we have the slide with the 4 documents? I think we've gone past it. Yes, it's right here. So hepatitis B is a major public health threat with a global burden that exceeds 300 million people living with hepatitis B. And we know that it has a burden that is pretty much 10 times greater than the HIV epidemic. In 2019, WHO data estimates that HBV was associated with over 800,000 deaths from liver cancer and liver cirrhosis. There were 1.5 million new infections in that year, with transmission mostly as a result of mother-to-child and early infant transmission. Therefore, preventing mother-to-child transmission will propel us towards our 2030 elimination goals. On the screen are 4 documents which provide guidance for this webinar. Firstly, the WHO evidence-based recommendations on antiviral prophylaxis for pregnant women with hepatitis B, which was published in 2020 but most recently, the interim guidance for validation of viral hepatitis, as well as the EMTCT validation document, popularly known as the Orange Book, and the Global Health Sector Strategy that was released last year provides guidance for this triple elimination of the three linked diseases: HIV, hepatitis B, and syphilis. And it promotes the hepatitis B PMTCT interventions, including maternal testing and antiviral therapy, and even the hepatitis B birth dose vaccination within the context of triple elimination. So this is an integrated person-centered service opportunity that harmonizes the epidemics and leverages on the pre-existing HIV platform, promoting harmonization across vertical platforms, including the HIV platforms, RMNCH, hepatitis, immunizations, and even health systems. We're very excited that the new Global Fund information note provides an exciting opportunity for country financing and country support. So here's the agenda to guide the session. Our guests will share their experiences and raise some key considerations, and we will try to navigate this session as succinctly and timely, and invite all speakers to keep the presentation within the 10 minutes allocated. We will have a presentation on the WHO guidelines and antiviral prophylaxis in pregnancy, and then important country highlights and experiences from Cambodia, Namibia, from China, and we will have our partners in Clinton Health Access to elaborate on the resource toolkit that will support countries. We sincerely appreciate our presenters from the Ministry of Health of Cambodia, of Namibia, and China, and we trust that their experience and insights will promote a collaborative learning, which we want, and problem solving. A big thank you to our speakers and colleagues from CHAI and from Project ECHO, the virtual learning platform. And without further ado, I would invite Dr. Philippa Easterbrook, who is an infectious diseases expert here at WHO headquarters, and she leads the development of hepatitis B guidelines process. Thank you, Philippa, and over to you.
Thank you, and good morning to all the participants. Welcome. We have, I think, now more than 80 who are online. So I'm going to be just very briefly orientating you to the guidelines and our plans going forward. And we're particularly keen to have your input. And this slide just summarizes on that front page the antiviral prophylaxis guidance that came out in 2020 with the algorithm. Next slide, please. So this slide gives some framework for the incremental approach we've adopted to the prevention of Hep B infection. And at the bottom of the pyramid, underpinning everything, is the 3 doses of infant vaccination, together with the timely birth dose, as being the most critical interventions for the prevention of mother-to-child transmission. And then in addition, ensuring the testing, universal testing for hepatitis B of all pregnant women and linkage to care as appropriate. HBIG, of course, is used extensively in high-income countries, but there are limited access in low and middle income countries as a further preventative strategy. And then finally, antiviral treatment, particularly for those subgroup of women with high viral load. Next slide. And next slide, that's great. So this slide summarizes the evolving WHO testing and treatment recommendations to date. In 2017, as I've already mentioned, the recommendations of the 3 doses of infant vaccination and the birth dose. In 2015, WHO published comprehensive WHO treatment guidance, and I've highlighted here the recommendation for treating all those with a Hep B DNA above 20,000 IU per mil, or hepatitis B antigen positive and in the context of abnormal ALT. No recommendation at that time was made on the use of antiviral treatment to prevent mother-to-child transmission, but the criteria I've highlighted were what a mother would qualify for treatment for her own health. And then in 2017, and then updated in 2019, was the recommendation that all pregnant women should be tested for HIV, syphilis, and hepatitis B surface antigen at least once and as early as possible in pregnancy. Next slide. So moving forward, the recognition was that there was new evidence from trials about the use of antiviral therapy for the prevention of mother-to-child transmission. There were emerging requests from regions and countries about plans for triple elimination of HIV, syphilis, and hepatitis B, and the recognition that particularly in sub-Saharan Africa, there remained major gaps in Hep B infant vaccinations in high prevalence countries. And also, based on modeling, concerns that timely birth dose alone may be insufficient to reach the elimination goal of less than 0.1% prevalence of Hep B surface antigen in 5-year-olds. Next slide. So in 2020, we published guidance on the use of antiviral therapy as an additional strategy for the prevention of mother-to-child transmission. There were 2 recommendations. First, the pregnant women, Hep B surface antigen positive, with a Hep B DNA greater than 200,000 should receive tenofovir from the 28th week of pregnancy until at least birth, in addition to the 3 doses of Hep B vaccination, including timely birth dose. And this was based on a systematic review demonstrating MTCT risk above that threshold of 200,000, despite Hep B birth dose and HBIG. And the second recommendation, recognizing often the limited access to Hep B DNA, was one in which antenatal DNA tests, where it's not available, e-antigen testing could be used as an alternative to determine eligibility. This was based on a systematic review demonstrating a sensitivity of 88% to 93% of e-antigen relative to a Hep B DNA greater than 200,000. And you can see the algorithm on the right, which places in the center of the algorithm who would qualify for the antiviral prophylaxis, and on the right, women who would qualify for treatment for their own health. Next slide. And it was recognized that the adoption of this antiviral prophylaxis recommendation would vary by region, depending on prevalence, service coverage of immunization, including birth dose, and the availability of affordable Hep B DNA assays and access to the antiviral prophylaxis and tenofovir. And in the context of high endemic settings, such as sub-Saharan Africa, with suboptimal coverage of infant vaccination, that would be the focus. In low endemicity countries already with high coverage of infant vaccination, that the adoption of this prophylaxis in the context of Hep B DNA would be a priority. Next slide. So moving forward, and this slide summarizes the recommendations across the continuum of care that exist from the 2015 guidelines, with also the PMTCT from 2020 at the bottom, and highlighting in red the new directions likely for our 2023 updated Hep B guidelines, with a lowering of the APRI threshold, lowering of the Hep B DNA threshold, consideration of TAF, and importantly, the potential to consider a recommendation that would be for all Hep B surface antigen positive pregnant women, regardless of Hep B DNA level. Next slide. Now, the advantages of this are the recognition at the moment, the very limited, particularly in certain settings such as sub-Saharan Africa, of access to Hep B DNA and even e-antigen tests. That such a simplified approach may overcome many of the implementation challenges to implementing this recommendation that we've observed, that the initial screening is inexpensive, and based on some preliminary modeling from Imperial College, that this strategy of universal antiprophylaxis in all Hep B surface antigen positive mothers is maybe more cost effective than a viral load guided strategy, particularly where diagnostics are not available or the antiviral drug cost is much cheaper than the viral load. There are clearly some disadvantages, that there would be unnecessary antiviral prophylaxis for the majority of mothers, the cost and inconvenience to mothers, and concerns about the ongoing postpartum management, that women that are likely to become pregnant again, whether a continuation of the antiviral therapy would be the most appropriate approach. And really, there's been very little empiric evaluation. More data is needed on acceptability, feasibility, adherence, risk of flares, and duration of treatment. But we're very interested to hear from you in this group about this. And the final slide, that any change and adoption of a universal prophylaxis approach must be considered in the context of the overall triple elimination initiative and the vision for an integrated framework across HIV, hepatitis B, and sexual and reproductive health services. The Triple Elimination Initiative is a global community commitment to the elimination of mother-to-child transmission or vertical transmission of HIV, syphilis, and hepatitis B, and focuses on a harmonized approach to improving health outcomes. And this framework of integration will include integration in the context of provision of testing, provision of appropriate maternal HIV, syphilis, HIV, and where eligible, Hep B treatment, and also linkages overall and integration with sexual and reproductive health services. Thank you.
Your mic is mute. The room mic is mute.
Computer in the moment.
Okay, can you hear me now?
Yes, we can, but there's an echo.
Okay.
Yes.
Can you hear us?
Yes. Yes.
Oh, you
Very
can hear.
well.
So, right. Thank you, Philippa, for that excellent presentation. And I'll be quite fast. And you've asked a very intriguing question, which I think we should all consider. You said, should we consider the use of universal antiviral prophylaxis in all hepatitis B positive mothers, irrespective of the viral load? Very intriguing. I would invite all participants to put your responses in the chat with your country, and it's something we can discuss during the discussion session. So if you have questions for Philippa, again, please put them in the chat. And we will now introduce a short poll to generate your responses and sort of stimulate discussions. We have 98 people on the platform already, and we hope you'll all participate in this poll. Diana, over to you for the poll, please.
Thank you, Fumi. Romina, could you pull up the polls? And Sandy, could you advance to the next slide? Thank you. At this point, we'd like to invite you all to take a short poll that will help us gauge where different countries are in terms of their policies and the implementation of the triple elimination guidance. So our first poll is asking if your country has a triple elimination policy that includes hepatitis B surface antigen screening, or whether it includes a surface antigen screening plus a tenofovir prophylaxis, or whether none, meaning that this, you do not have the policy, or the policy does not include both the screening and the tenofovir. Glad to see more responses coming in. It would be good to hear more from the countries that do not have the policy and where they are in terms of the plans to enact such a policy. Thank you very much.
We actually have 36 responses already, as you can see. 19 for screening policy only, 18 for both policies, 5 for none, and we encourage more participants to respond to this question. So we have only 38 people, now it's 39. Right, it's increasing. Now we have over 40 people responding, and we encourage you to respond. Thank you very much. Diana, over to you again.
Great. We'll give it a few more seconds as I see more polls coming in. And perhaps we could go to the second question, where we ask on the implementation of these policies. Romina, could you launch the second question? Thank you. So we want to know whether women attending antenatal screening, antenatal clinics have access to hepatitis B surface antigen screening, and where they have access to this. Is it at the primary healthcare facilities? Is it only available in specialized centers? Or is it available only in private hospitals? We have 16 people responding, and I see that most countries have it available in primary healthcare facilities. It would be good to understand those who do not have it available, what are the challenges and how WHO can support in order to ensure implementation. I would also like to know on issues related to stockouts of tests in areas where the policy is there, but implementation is lagging. Great, we have 46 responses, 47. And the last question, Romina, if you could launch the last question, where we ask if your country has, yes, if pregnant women in your country have access to hepatitis B DNA testing, and where they have access to this. And in reflection to presentation from Philippa, understanding on the new guidance to lower the threshold for the viral load, would be good to understand where countries have access to hepatitis B DNA testing, so as to see how these changes in the guidelines will be implemented. Thank you all for those participating. We have few responses to these questions. Would like to encourage more of you to go ahead and complete the poll so that we can go ahead to the discussion. Put me over to you on the reflection on the polls that you, on the results.
This is actually very interesting, because looking at this question 3, now many more countries do not have DNA at primary healthcare facilities. Actually, only 21% of the nearly 50 people that have responded have DNA at primary care facilities. 40% have DNA available at the specialized centers, and this is great. And of course, it's a subject we will discuss very, very interactively during the discussion. So thank you so much for this poll, Diana. And at this time,
can we, Romina, end the results and show the results to the participants?
Yes, can you show the results? Romina, can you show the results, at least the poll 3?
Yes, full meets up on the screen.
The result is on my screen, but not on the general screen. I guess we can come back to that. Thank you very much. And at this time, I would welcome the representative from Ministry of Health of Cambodia, Dr. Cheryl Keller, who is a public health specialist and the International technical advisor of the Cambodian National Maternal Child Health Center since 2016. She will share with us the experience of Cambodia. So I invite you, Dr. Keller, to take the floor. Thank you very much. You're welcome.
Thank you. Since I have only 10 minutes, I will
Yes.
dive right in. Next
Okay.
slide. Okay, next slide. First, to give a little background about the maternal health coverage situation in Cambodia. We now have nearly universal ANC coverage from a trained provider, about 99%. And that is almost entirely through the public sector. There is not much private sector involvement. 86% now have 4 or more visits. Most of this ANC is delivered by very small community-based health centers, large number of them scattered throughout the country, and they do not have laboratories. We also have nearly universal facility deliveries with a trained provider. Here, though, about 1/4 is in the private sector. And with the government sector, it's split between hospitals and these smaller health centers. Next slide, please. Next slide, please. Okay. I will start with talking about HIV and syphilis PMTCT because these have been in place much longer. We began first with HIV and then phased in syphilis, and only now are phasing in hepatitis B. Currently, 90 to 95% of pregnant women are screened for syphilis and HIV during ANC. We originally had a very high HIV prevalence of pregnant women at about 3%, and it has steadily declined to under 1%. Syphilis prevalence initially did the same thing. However, in the last 2 or 3 years, prevalence has shot up, and it's actually now higher than it's ever been, both in high-risk groups and the general population of pregnant women. We had initially low treatment rates for syphilis in pregnancy because women were referred to STI clinics that were often in another district, and there was also a feeling of stigmatization for a pregnant woman to go to an STI clinic. So we have very recently changed to treating at maternity sites rather than STI clinics and based only on TPHA, and that has worked very well. Next slide. Just to show you the evolution of this 2007, at that point, it was just a pilot for HIV screening only in Phnom Penh, so that the coverage was low. By 2010, we had geographical expansion, but still using tests that required a lab. So it either had to be done in a hospital or a health center had to try to send the specimen somewhere else. And as you can see, this did not work well. In 2015, we started point-of-care testing with a simple finger prick rapid test, and that was a complete game changer. As you can see, the coverage shot way up, and it remained at about 80%. The next real turning point was between 2016 and 2019. We introduced an integrated package of blood testing that also included hemoglobin screening using handheld hemoglobinometers. And this eliminated pretty well the problem of anybody opting out, because while some women would opt out of just HIV and syphilis screening, they all were interested to get the blood count. So that was the next sort of game changer, and we're now at a very satisfactory level of screening. Next slide. Okay, in terms of the strengths for the screening for HIV and syphilis, the point-of-care testing with the rapid kit is very easy. Even very simple health centers with no laboratory can do it. Our very high ANC coverage rate, almost all of it in the government sector, enables us to easily reach women. There's very high acceptance by the midwives. The client acceptance is high, especially after integration with hemoglobin testing. And the referral pathway for HIV treatment works very well. And the syphilis referral pathway that was problematic is now working well since we integrated it into maternity service. And so far, and this, so I emphasize, so far, the Global Fund has supported the cost of the test kits. Next slide. Our challenges are, first of all, ensuring a constant supply of the dual test kits down to facility level. This is a constant headache. Even when there is no shortage nationwide, it can be a problem with the logistics system of ordering and supplying peripheral health centers. We're still able to get coverage at a high level, mainly because women have multiple ANC visits. So even if the facility was out of stock on the first visit, they can usually catch them, on the second, third, or fourth. Our other big concern is long-term funding. The test kits are totally funded by Global Fund. We have gotten some pushback from them, and it is indication that they want to see this shift to government, but the government is already struggling to finance a greater share of ART. We also have a problem with lack of participation from the private sector, and the recent increase in syphilis has been a challenge in terms of supply of treatment. Next slide. Now, in terms of hepatitis B, it's endemic in Cambodia, and as in most of Asia, it's mainly due to vertical transmission. The current prevalence in the general adult population is about 4.7%, and similar in mothers of young children. Seroprevalence in children in 2006 was 3.5%. It has decreased to about 0.5% 12 years after beginning the vaccination program. But that is still well above the goal of 0.1%. And in children with HBsAg positive mothers, the prevalence remains high at 10%. Hence our interest in introducing ARV. Next slide, please. Just to give you the timeline of where we are on this, in 2005, the HBV vaccine, including a birth dose, was added to the immunization program. In 2016, the second national PMTCT strategy included hepatitis B for the first time, although the activities at that point were limited to the birth dose of HBV and a study of ARV feasibility. From 2017 to 2019, the TOP-PROM study was done in Cambodia, which validated the use of a combined HBe antigen and ALT algorithm as a proxy for viral load, and also established the feasibility of ARV prophylaxis, at least in urban areas. Based on that experience, in 2021, the clinical guidelines for PMTCT were revised to include ARV for women meeting the criteria for high load of HBV. And the new PMTCT strategy for 2021 to 2025 includes ARV to reduce MTCT of HBV, starting first in Phnom Penh with a gradual scale up. And then in 2022, we began this in Phnom Penh. And also in 2022, for the very first time, the MOH allocated some limited funds to a viral hepatitis program. As I'll discuss in a bit, the PMTCT started a little bit ahead of the national viral hepatitis program, and that has been a problem for us. In 2023, this year, we plan to evaluate the Phnom Penh experience, and then hopefully in the coming years, expand gradually to another 12 to 16 rural districts, depending on the availability of the diagnostics and treatment. Next slide, please. Just looking at achievements, looking at the coverage for birth dose of HBV, you can see that we only have data from 2010. This is data from demographic and health surveys. So that captures both public and private deliveries, which is important, as our health information system does not. And you can see that as of 2021, we're up to 94%. This is very much thanks to the fact that most deliveries are happening in hospitals. It would have been almost impossible to get that level of coverage otherwise. Next slide. The screening in Phnom Penh, it only began in June. And in June and July, the training was still being rolled out to all facilities. It reached all facilities by August. And since then, as you can see, we now have over 90% of the women being screened. So that part has gone quite easily. Next slide, please. Just to emphasize, the HBsAg screening at ANC is a very new intervention. So far in just one province and running for less than a year. The onset was delayed by a year due both to COVID restrictions, which prevented the training sessions, and also delays in getting funding for the HBsAg rapid test. Another challenge that we faced very quickly was that it turned out we originally thought that treatment would be available at least the national level hospitals in Phnom Penh. But we quickly found out that in fact it was not, because the government was not providing the drugs or diagnostics at that time. So we had to rapidly create a diagnosis and treatment capability within a large maternity hospital, which is what we did. ANC providers refer all the pregnant women to the maternity hospital. And there we are currently purchasing HbA/Ag rapid tests and the tenofovir out of user fee revenue. We're using the combined HbE-ALT protocol. This is a far from perfect solution. It's very cumbersome to arrange. We're not able to buy at a good price because of various procurement restrictions on using user fee revenue. And it also unfortunately means that costs have to be passed on to clients. We hope this will just be temporary. Next slide, please. Preliminary results, we're finding 2.8% of the ANC clients are positive, surface antigen positive. That's less than the national preference, but remember, this is in the capital city, so that's not really surprising. Of the women who are HBsAg positive, about a little over a third meet criteria for ARV. That is to say, they are HBe positive or they have an ALT over 40. And this was what we had expected based on the TAPROM study. So it seems about right. There seems to be some loss to follow-up between testing surface antigen positive and follow-up testing, but it's too early to quantify because of the time lag, as the testing usually is done around the second month of pregnancy, and we have up to the 28th month to do the additional diagnostics and start treatment. And likewise, it's too early to assess what percent of women actually get the tenofovir. We plan an external evaluation of this effort later this year. Next slide, please. Now, some of our strengths for doing this, the very high rate of facility delivery, which gives us a high rate of birth dose vaccine. The very high rate of ANC makes it easy to reach pregnant women. And it has been very easy to integrate the HBs antigen testing into ANC everywhere, since they were already doing point of care HIV syphilis screening, and the HBsAg has a point of care test available. Next slide. Now, our challenges, as I already mentioned, we started the screening before there was really a capability to treat public, and that has been HBsAg tests are been funded by the Global Fund, but we're not sure that will continue. The tenofovir and the HBe so far are being procured by the hospital, and that's very non-cost efficient and requires passing costs on to clients. We are going to try to get the funds for that as well in the next Global Fund request, but we don't know if that will go through. There are now government-funded funds available and a procurement being made, but it's targeted only to certain rural districts. So in those areas, we will try to scale up using government-funded health commodities. But in Phnom Penh at this point, we're still donor dependent. The viral load testing is extremely costly. It's not only limited in where it's available, but it's very, very expensive. If you compare this to the HBe antigen, which costs less than 50 cents a test, you're looking at $12 to $15 per test. So a huge difference. Plus, I expect that when we do try to use viral load, we will quickly run into a problem of volume because the machines are used across programs, and the sheer volume of pregnant women that would need testing is likely to clog the system. However, we have a real problem with the HBe in that there is no WHO pre-qualified product available. I should also mention there is no point of care product. There are rapid tests, but they do require venipuncture and centrifuging. It's a plasma or serum test. So it does require, it can't be done at point of care in a health center. It can be done though in any hospital, and it's fairly simple. Other constant challenges is just the time lag between ANC1 and eligibility to start ARV makes tracking and calculation of coverage very difficult. And we don't have ongoing data on the birth dose of HPV vaccine from private providers. We have to rely on periodic DHS for that. And I think that completes my presentation.
For me, the room mic is muted. We cannot hear. Still cannot hear.
All right, can you hear now?
Yes, with an echo.
Okay.
Here.
So where's Can you hear us now? This is ridiculous.
Go ahead. Now you hear us?
Yes,
Okay,
very
so
well.
thank you very much to Dr. Cheryl, who has provided such valuable insights. And just to mention 3 takeaway points: the point of care transformed the response, the integrated blood testing, and the TAPRON study is very exciting, and we'll learn more about this in the discussion. Using a combination of e-antigen and liver enzymes as a proxy for viral load. So thank you very much. Financing the response, procurements of commodities, and access to DNA testing. There are real bottlenecks in many countries, and even more so in low middle income countries where the burden of hepatitis B infection is really great. I would like to invite our next speaker, Ms. Naomi Shupala, the Director of Primary Healthcare Services in Namibia, who oversees the implementation of elimination of mother-to-child transmission of congenital syphilis, hepatitis B, maternal, newborn child, adolescent nutrition, and other primary healthcare programs. She has been part of the PMTCT program in Namibia in various capacities and is also leading the request for validation of triple elimination in that country. So, Naomi, we welcome you very warmly, and you have the floor for your presentation. Thank you very much.
Thank you, Dr. Fumi, and thank you to all the participants. Good morning and good afternoon to you all, wherever you are. It's my pleasure to join this webinar, and I'm happy to share the Namibian experience. Next slide. So Namibia launched the national roadmap for the elimination of mother-to-child transmission of HIV and congenital syphilis in November 2020. However, by then, we only considered the dual elimination of HIV and syphilis and not hepatitis B. With the release of the WHO Orange Book, Namibia immediately considered and commenced engagement of the National Validation Committee and stakeholder, as well as the ministerial leadership, to approve and consider converting or transitioning from a dual elimination to a triple elimination. Although the roadmap was already launched, we decided to develop an addendum that we appendixed to the approved roadmap. Next slide, please. Just to provide some background, as my colleague, Dr. from Cambodia has just presented now, the PMTCT program in Namibia is fully integrated within the antenatal care services. There are several platforms that are conducive and kind of catalytic supportive of our agenda for triple elimination. The antenatal care services is provided in the private sector at no cost. This includes all the laboratory testing and treatment. It's a routine that all pregnant women will have HIV, syphilis, and hepatitis tested during the first antenatal care. For HIV, we are doing a rapid testing and we are doing cash sharing because this testing is being done by a lay cadre who are present both at the facility and community level. Unfortunately, we don't have the dual rapid test kit for HIV and syphilis. It is still under discussion. What you can see also in this slide is that all the logistics related to testing and treatment are fully funded by government. The government of the Republic of Namibia is funding 70% or more of the HIV response, including ARVs. What you are seeing on the right-hand side of this slide is our coverage for hepatitis B. We have rolled out the best dose and we are giving those additional 3 doses up to 14 weeks. Next slide. In terms of opportunities, challenges, and solutions, the hepatitis B, syphilis, and HIV triple elimination is kind of coordinated under the primary health care and is integrated within the MCH program, where the expanded program on immunization is also housed. HIV testing and treatment is 100% rolled out to all the primary healthcare facilities. We have been looking at the data, both for HIV testing, hepatitis, and syphilis. Although we have aggregate data available in the demographic health survey at the district and national level, the only challenge that we have faced is data on women who have completed treatment for hepatitis B and syphilis. There is tenofovir treatment offered to women who are co-infected with hepatitis B and HIV. However, we have not yet rolled out DNA testing at primary healthcare facility. And I think this is a challenge that is demonstrated in most countries, as we have just seen in the result of the poll. Next slide, please. Now, in terms of the addition of hepatitis B to be part of the elimination, as I have alluded to, we have developed this addendum that we have attached to the roadmap to guide us in terms of the implementation. And we have worked on the M&E system to strengthen it so that we have data that are kind of lagging behind in terms of us to be able to validate for the elimination, including hepatitis B. However, I'm happy to share with you that as a country already, if you look on the target that are presented on the right hand of the slide and progress that has been made so far, I would say Namibia is on track toward on the path to the triple elimination. Considering that hepatitis B testing is universally offered during antenatal care services for all the pregnant women during phase A and C. We are also offering the universal hepatitis B birth dose within 24 hours in the postnatal ward, and those additional doses that are offered up to 14 weeks. The coverage in terms of hepatitis B for infant vaccination is 90% and above. This is really just to demonstrate that even though we had not considered hepatitis B in our initial roadmap, the country is already advanced and on track for the validation of a triple elimination. In terms of the next step, next slide, please. The country, we are really putting more effort just to ensure that we continue with the implementation of the roadmap. Now, as a triple elimination country, we will continue to ensure data quality monitoring, especially the data coming from the private sector that has been more of a challenge. Namibia is ready to apply for the path to elimination of MTCT for HIV, syphilis, and hepatitis B. And I hope other countries will also follow suit. Thank you, Dr. Fumi. Over to you.
Thank you very much. That was an excellent presentation, and it is really inspirational to see Namibia building triple elimination from a platform of dual elimination. And one of the strong lessons is the need for data systems that not only records HIV, but also hepatitis B and syphilis. We laud the aspiration of Namibia to be the first country in Africa that is planning towards triple elimination. Our next speaker is Grace Singh, and she's the program manager for viral hepatitis at Clinton Health Access. Grace led the development of this resource toolkit on global fund opportunities for hepatitis, which was published in December, and she's now coordinating support to countries for advocacy to include hepatitis components in their applications. And we're collaborating and working together on that front. So thank you, Grace, you have the floor. Over to you.
Thank you so much, Funmi. Yeah, so I think we're running a bit behind on schedule. So if we could get on to the next slide,
absolutely.
and I'll try and be succinct.
Next slide.
Thank you. Yeah, so in terms of global funds, so the latest policy allows for countries to prioritize integration of viral hepatitis, prevention, diagnosis, and treatment into multiple service settings. And this includes HIV ART clinics, antenatal care, sexual health, and harm reduction settings. So this policy really sets out to enable countries to integrate hepatitis services within existing service delivery platforms to address hepatitis C and hepatitis B needs among specific populations. So this includes people living with HIV, key populations, and pregnant women. This supports integration not only aligns well to address the health needs of these populations, but is also supportive of global agendas around universal healthcare. Provides a much needed boost towards progressing towards SDG goals for infectious diseases. I think we're all aware, and as mentioned today through some of the country examples, funding for hepatitis is limited globally. So this policy really does offer an opportunity for countries to unlock funding to introduce or scale hepatitis programs within specific populations. And as Funmi mentioned, so to equip people who are interested in mobilizing around this funding opportunity, CHAI recently developed and published this resource toolkit. So if we could go to the next slide, and I'll run through the contents. Yeah, so as mentioned, CHAI led the development of this. It was with the support of a coordination group of a number of partners who provided inputs and review support, including colleagues from the WHO. So thank you to those of you who participated in that. In terms of the content, so the toolkit contains a summary of what the hepatitis-related policies are for this cycle. It contains a series of country case studies, so 5 countries where they have previously successfully advocated and leveraged global fund resources for hepatitis services. It also includes a checklist on what content would be useful to develop and include in a hepatitis-related funding request, as well as an outline of activities that may be needed to support funding request development, plus a number of other items listed here. The document is long and aims to be comprehensive and is set to be used by a wide set of stakeholders. There is a how to use the toolkit section at the beginning of the toolkit that may help navigate to the pages that you need. In the next few slides, what I'll do is to summarize some content from bullet points here, 1, 2, and 4, and I will try to focus on content relevant to Hep B PMTCT. So if we could go to the next slide, please. So this is a screenshot of what's in scope, and this reflects what's in the toolkit as well for hepatitis. I won't go through the full scope in the interest of time and just instead focus on Hep B PMTCT. So for pregnant women and breastfeeding women, within the HIV allocation, countries can request resources to support a triple elimination approach within the ANC setting. So what this means is countries could request funding to supply HIV, syphilis, and Hep B testing, linkage to viral load testing, and the Hep B prophylaxis treatment. There's also scope to request funding to support the programmatic delivery of Hep B birth dose vaccine. Global Fund's been very clear that they will not produce funds to support the procurement of the Hep B birth dose vaccine, but the programmatic investments could be looked at. And then just to note that countries could also explore health system strengthening investment to support the integration of hepatitis services and strengthening of the delivery. There's a whole number of examples within the toolkit, but just to pull out a few here, it could be, training healthcare workforce, optimizing diagnostic platforms to have integrated multi-disease options available. So I think overall, you'll see that the policy for this cycle is much clearer around hepatitis services. And it's worth noting that these hepatitis-related policies from Global Fund have evolved over time. And there are examples of countries requesting resources to support hepatitis services in previous cycles. So if we could go to the next slide. Yeah, so within proposals for this current grant, we are aware that at least 13 countries requested resources to support Hep B screening and prophylaxis as part of services for pregnant women. And then in terms of implementation, I think we've already heard from the Cambodia example from Dr. Keller, but Global Fund resources have been used to strengthen the ANC setting. And then as part of this current grant, some resources were put towards Hep B screening kits for pregnant women. And then in Uganda, triple elimination programming has been growing. And as part of this current grant, Global Fund resources were used for a mix of investments in commodities, such as Hep B viral load, and then also investments in the system strengthening. So investments to integrate sample transport, logistics, labs, procurement, and M&E. So I think overall, this slide paints a picture of momentum, and that many countries are already advocating for funding and using funding in this area. If you're interested in examples for hepatitis C and the policy scope on that side, you can find those in the toolkit. So could we go to the next slide, please? Yeah, so now looking more forward and talking about approaching the funding request development for this cycle, you'll find in the toolkit from page 21, we have outlined potential activities that stakeholders can undertake for developing and including hepatitis-related asks in the applications. You'll see here that we have 3 broad steps in gray. For each of these in the toolkit, we've outlined some key intel gathering questions and sub-activity areas that may be needed. There's an example set of questions in the speech bubble here on the left. Due to time limitations, I won't go into this any further. And instead, if we could go to the next slide, I'll speak to some of the lessons learned from CHI colleagues who are supporting funding request development for Hep B PMTCT during this cycle. So yeah, we're aware that many countries are actively exploring and pushing for triple elimination funding requests. And so just some reflections in terms of approach so far. We recognize that having a really clear understanding of what the current PMTCT programming is like in country and using that to identify where funding and the Global Fund policy is most pertinent. Proactive engagement across the various verticals from HIV, hepatitis, syphilis is needed, both to ensure awareness of the latest policy and also to gauge interest. Ideally to determine the funding ask around triple elimination early and ensure that that is informed by current programming and stakeholder consensus. And while there may be appetite for funding triple elimination, as funding priority negotiations evolve, continued effort to keep triple elimination on the table is needed. And then just reflecting on what the funding asks are looking like. So I think we're observing that countries are exploring a breadth of triple elimination programming, whether that's expanding from solely HIV PMTCT investments or dual PMTCT investments. Some countries in terms of scale are looking at initial pilots where they'll look to introduce a smaller scale and then build upon that in the future. Others are, whether triple elimination programming is a bit further along, assessing the gaps that could be addressed with Global Fund support. And yeah, just to note, it's a mix of sort of commodities as well as RSSH investments. So yeah, if we could go to the final slide, please. So yeah, as a final slide, we wanted to just reflect on where we are seeing potential interest for hepatitis-related funding asks. This is very much
Grace,
a
I'm going to ask you to wrap up quickly, please.
Sure. Yeah, so this is very much a Chai lens. So you'll see here that we're currently engaging across just over 20 countries, and we're hearing interest from about 12 countries so far, 9 of these Hep B PMTCT related. Each country is kind of at different stages, some a little bit earlier on and yet to engage with wider stakeholders. In other settings, it's far more progressed and the proposal writing is underway. I've noted here that Chai is supporting across a number of areas and where feasible, open to coordinating more closely with WHO colleagues on this call to support the process. So yeah, back to you from me.
Thank you very much, Grace, for this great presentation and amazing work to facilitate that particular process with the Global Fund and including hepatitis in the new funding cycle. We're moving now to the Q&A. Just very quickly to introduce myself, I'm Dr. Niklas Luhmann as well, working with the Global Hepatitis Program in Geneva in WHO. And the Q&A I will facilitate with Dr. Kiyohiko Izumi from our Western Pacific region, who has just put his camera on. Hello, Kyo. We really want to engage you in this webinar series. So I will hand it over to Kyo for a first round of questions. And then I have noted already a couple of topics that are coming up. So please, those participants that can stay on, I will pick on some of the questions in the chat and bring you in as well, the participants that have not have been speakers. Thanks. Over to you, Dr. Izumi.
Yeah, thank you so much. So to start the Q&A session, I wanted to invite Dr. Eileen Wang, Director of the Maternal Health Department of the National Center for Women and Children's Health, China CDC. China has made remarkable progress in this area of elimination, and we invite your brief reflection on implementing PMTCT in the work frame of the triple elimination. Please reflect more specifically on the subnational approach and the funding approach, including national funding and the health insurance developed in China. So hand over to Dr. Eileen.
Okay, thank you so much. It's my honor to be here to have an opportunity to talk about the triple elimination of anti-CT in China. In 2010, we based on the PMTCT of HIV, we planned carried out integrated PMTCT. At that time, it's about 1/3 of counties. And from 2015, we expanded to the whole country. For PMTCT of hepatitis B, we did integrated screening for pregnant women, for all pregnant women. And we also asked them to, for the birth dose, we asked them for the 24 hours, now it's 12 hours, because it's the time is very important for infants. We also ask them to provide the TDF treatment for the high-risk pregnant women. And last year, we have the data for the PMTCT of hepatitis B. It's about 99% pregnant women go to HPV screening, and also have 435,000 pregnant women is positive, and 54,000 get TDF treatment. It's about the rate of treatment is 12.5%. 99% get HB. So last year we also published the action plan and validation tour in China, and we will evaluate and certificate on the province basis by 2055. We plan to complete certification in 12 provinces. Compare with evaluation of HIV and syphilis PMTCT, we think is for evaluation for in elimination for hepatitis B, there is a special challenge in China. For example, the vehicle for the lab support system is weak in China for the hepatitis B, because it's a common disease in China, and we compare with the HIV and the syphilis. We have strong syphilis and STI and HIV laboratory support, but for the hepatitis B is not very strong. This is one challenge for us. The other challenge in China is the community participation, because for HIV is okay, but for hepatitis B is not strong. It's just a small organization to support for pregnant women. So this year we want to do some activities to support them. We plan to support apply the elimination for triple elimination, maybe 2026 years for WHO. But there still have so much work to do. For me, thank you so much for WHO give China opportunity to share our experience. I also get a lot from Cambodia, Namibia, and Greece. It's great opportunity to me. Thank you.
Thank you so much, Dr. Eileen, for sharing your great experiences in China. I'd like to congratulate the publication of the National Action Plan on PMTCT. So the insights from China providing huge encouragement to the other countries and very useful. So now I will hand over to Nicholas for more comments from the participants and the chat. Over.
Thank you, Dr. Ling, and thank you, Dr. Izumi, for that part. It's really amazing to hear from China that ambitious program in this area as in many other areas. Thank you, Dr. Ling. Please stay on for some questions that might come. So we're moving now to the question and answers. It is really an interactive session. If you can raise your hand, if you want to ask a question, if you want to share your experience, if you want to highlight something that has been highlighted in the chat already, that is fine. While people are raising their hand, I would like to come back to 3-4 topic areas that I identified in the chat that was very active and really a fascinating session on this very important topic. The first one I saw was around prophylax all, and for example, Dr. Huma Qureshi from Pakistan commented that this might be useful. I wanted to see, and Dr. Keller said as well that it might be, depending on prevalence, how huge or the proportion of overtreatment is. I can read that Dr. Kokomotso seems to plan a Prophylax All project in his country. Are you on? Can you share in which country you are working? And you said in the chat you will start soon. Can you share a little bit about your plans and your approach? This is possibly very interesting for the participants if you're on.
Thank you very much, Nicholas. I think we have 5 more minutes, but I wish to request maybe an additional...
You're unmuted yourself, I think.
No. I think I'm going to request an additional 10 to 15 minutes for participants who are available. There are currently about 100 people on the call, and we've had some technical challenges, so perhaps an additional 10, 15 minutes for questions, and we'd really like to see raised hands. We'd really like the audience to participate. Please go ahead and take the floor and ask your question directly. Thank you, and over to Nicholas.
Okay, thank you. I think that's very good. So if Dr. Kogumotoso is on for his Prophylax All project, please raise your hand or just come in. If you're not on anymore, I saw as well Dr. Umutesi commenting on the multiplex test. I think that's a very interesting area. I just want to share that manufacturers have so far prioritized hepatitis B, C, and HIV combinations, but there are many discussions ongoing on the importance of that multiplex test. And we're hoping to work on a WHO recommendation as well in this area soon, just to share that. But Dr. Umutesi, if you can maybe share your thoughts about how this would be useful and what you see as opportunities, if you're on. Okay. Other comments can come from the chat if you want. Otherwise, there was a question as well around engaging the HIV program around the Global Fund requests. So I think maybe, Grace, that's a question to you. I think this is pretty crucial for the Global Fund because it is still led with the HIV program. Is there any countries where there is good practice examples or lessons on how the HIV program was engaged early enough so that this inclusion could be well discussed?
You know what, Nicholas? I actually think they can't raise up their hands or make any comments. I suspect they can't, because now I even see more comments in the chat. So the audience may not be able to interact or raise up their hands. So we'll continue with comments in the chat. Yeah.
I think people, Grace, did you hear that question?
Hi, yeah, happy to jump in there. So yeah, in terms of a good example, I think you're right. It's very crucial to have engagement and aligning and collective consensus on pushing forward with triple elimination. So for this cycle, I think we're nearing window 1 in March, and so some countries are getting close to sort of finalizing applications. So if I was to call on a specific example, I think in the Uganda setting, there has been a lot of engagement with the HIV PMTCT lead. There's been a collective review of what current PMTCT programming looks like within Uganda and identifying pain points, so challenges across the 3 diseases, and sort of identifying where the Global Fund policy and resources could be used to address. So some of these areas could include, optimizing the diagnostics piece. In Uganda, there is a mix of central lab testing and sort of more localized testing. So trying to identify if there's ways to work around that. But what we've observed is, a coming together of the hepatitis lead at the ministry side and also the HIV to really think through these issues and iterate on what funding requests make sense for the setting.
Thanks, Grace. Dr. Kumar, you seem to have a question for Dr. Ling from China. Is that right? Can you unmute and ask your question? You started a question in the chat.
Yes, doctor. Thank you very much. So I just wanted to know that during the pandemic, COVID-19 pandemic, how did China manage to provide treatment for hepatitis B for elimination of mother to child?
Dr. Lin, I think that's a question to you. Did you understand the question?
It's mean how we provide the treatment in China, yeah, for the prophylaxis treatment, yeah.
I think I understood the question was, how did you work around the continuity of your services during the COVID pandemic?
Yeah, there's still so much influence for the COVID-19 epidemic in last 3 years, but because it's not just in the big city, it's much more influence for in China. So most counties is okay for us. But even for the epidemic, we have the how to say routine antenatal service is continue. So even they have stay home or they ask them for the go to hospital, they also have the opportunity to go to hospital to get their antenatal care. We have also asked them minimize time of the antenatal care. So the routine service is okay for us, especially for the positive pregnant women, for HIV, syphilis, and hepatitis B. We also have the how to say the internet counseling. Also have the special way for the for go to hospital get the treatment. It's okay.
Thank you, Dr. Ling. Thanks. I had 2 more questions. One is to Philippa. Philippa, there was a question around the use of TAF in the framework of hepatitis B PMTCT from Armenian colleague. Did you want to quickly come in on your view on that, please?
Sure, thanks very much. So we are looking in the updated Hep B guidelines at the issue of TAF and the potential positioning of TAF. As you may be aware, in the HIV guidelines, TAF is not replacing TDF, and its positioning there is in the context of special circumstances, those with renal disease, those with osteoporosis, and for consideration for children as well, replacing TDF. For the Hep B guidelines, we're looking at the data of the HIV-related experience with TAF, but also in the context of hepatitis B. So I think we'll look to see what the added advantage is and what the cost implications are and make recommendations on that basis. Thank you.
Thanks, Philippa. I hope that's helpful for the Armenian colleague. Another area that came up, or where I had a question as well to Dr. Keller from Cambodia, I wondered if you can develop a little bit more on how well your algorithm in the TAPROM study, where you used hepatitis E antigen with transaminase levels, how well did that concur with high DNA levels? Can you say a little bit what were the main findings in more detail there? Did you think that, and do you think this is a very useful algorithm to use hepatitis E with ALT levels?
Yes, thank you. Combining it with hepatitis E alone for picking up viral load above log 10 5.3 was only 6.8% sensitive, but very high specificity of 99.2. It did a little better with higher viral loads, log 10 7.3, it had 81.3% sensitivity. But we were not satisfied with that, and that is why the second round looked at combining the HBE plus ALT. With the combined algorithm, we now have almost 80% sensitivity for viral load above log 10 5.3 and 93% sensitivity for viral load above 7.3, which is quite good. We're happy with that. And the specificity dropped to only 88%. So basically, we are satisfied with the combined protocol. Our dilemma, however, is that study used Abbott SD Bioline HBE antigen test, which Abbott is no longer producing. So that what we are using right now, although the technical file indicates, it's comparable level of correlation, we do not have that level of validation for it. And then there are other products out there that we have really no idea about. So the lack of pre-qualification of the HBE products, the fact that the specific test that was validated in the TAPROM study, the specific product is no longer available, is of some concern. And we've been talking to the Pasteur Institute as to whether they could do a validation study for us of the products that are now currently on the market. Specifically, we're using one from the UK, from BioPanda, and we would very much like to be able to validate that it is at least as accurate as the no longer available Abbott product was. However,
yeah, thank you. I mean, we note very well as well in the chat, there's a real need, to engage with manufacturers around e-antigen tests with high quality, and as well the triple multiplex tests that combines HIV, hepatitis surface antigen, and syphilis. Very short comment on what you said, Philippa, in the chat around high ALT levels and treatment for their own health for pregnant mothers. Then I will hand on to Fumni so she can ask her question to the Namibian colleague and then close. Philippa, did you please want to come in with your comment, or I think it's nicer to just engage around the combination with ALT levels?
I think it was just making the remark that having these simplified algorithms for identifying those in need of prophylaxis is very helpful. But once you have an abnormal ALT, that would normally be an indication for lifelong treatment for your own health. So it was really just to get a response to that.
Thank you, Philippa. I'd like to direct a question to Miss Naomi from Namibia, just to share some of the challenges, because I know they had some reporting data for hepatitis B and syphilis testing at antenatal facilities, and how they are working towards ameliorating these challenges of data reporting, especially for a country that is considering validation. So are you still on the call?
Yes, Dr. Fumi, I'm still on the call.
All right, thank you very much. Can you tell us very briefly about data issues?
Okay, so as I have indicated in my presentation, in Namibia, we do test for hepatitis and syphilis in ANC. However, for women who test positive for syphilis and hepatitis B, they are not necessarily treated in the antenatal care setting. They are treated in OPD. And the data is usually in the paper-based register. So that has been our challenge, to get the exact coverage in terms of treatment for both hepatitis and syphilis. What we are trying to do in the meantime is that we are taking a two-pronged approach. One, to do a quick, rapid assessment to get this coverage by looking at the data available in the paper register. And the second prong is to institutionalize treatment within the antenatal care setting, so that the treatment data is also captured in the antenatal care register. So we have to modify our ANC register to capture for this information. Thank you.
Thank you very, very much. And I must, as we round up, it's been an amazing webinar. And I think we have accomplished our goal of knowledge sharing and amazing participation and engagement from all in the chat. Just to highlight what is coming next in WHO for PMTCT. And the first is the revision of the hepatitis B treatment guidelines, including perhaps simplification of this antiviral prophylaxis. Now, WHO is also developing an implementation guidance for country action using the 4 PMTCT prongs. And we're aware of the challenges of WHO PQ platforms for point of care tests, for e-antigens and DNA, and these are ongoing in process. Additionally, WHO is supporting the workshops for countries, and we encourage countries to include some hepatitis PMTCT support within the Global Fund applications. We are fully available for support, for further information and technical support. And I think we have put our contact details in the chat, and you can easily get in touch with us. Our next session next month is on integrated national strategic planning, including for triple eliminations and lessons learned from prioritizing plans and costing plans. We would like you now to put in the chat which topics are desirable for future meetings and contact us to suggest how we can better serve you during these webinars. I thank the 80 people that are remaining on the call. We appreciate your valuable time, and we look forward to our meeting the next month, which will be on March the 16th. Am I correct?
Yes.
On March the 16th. So if you have any comments to help us in developing the presentation or suggestions, please put in the chat. As we close out this webinar, we will leave the platform open for another 4 to 5 minutes for whoever is interested to fill in the feedback form. We would like to hear from you. We would like to hear your suggestions of what more we can do to make this platform user-friendly and to engage countries to action. So on behalf of the entire WHO team, we say a huge thank you to the 100 people and more who participated, incredible speakers from the various countries, Cambodia, Namibia, China, and Chai, and of course to the ECHO support team based in India at this point. So thank you very much to everyone. I think we can close this session. So we thank you very much, and thank you and goodbye. But we will leave the platform open for you to fill the feedback questions. I think the link is in the chat, and Romina, you could put the link in the chat again because I'm sure it's moved on. So thank you everybody and goodbye.
Thank you, Funmi. For some reason, the link is having a little bit of glitch from backend, so we will be sharing the same via the follow-up email along with the session.
Okay. Okay. Thank you very much.
Thank you.